Mike, tell us your full name and your position now as well.
Right. So my name is Mike Johnson. I am a regional director at Bayada Home Health Care, which is the headquarters are in Morristown, New Jersey. My responsibilities as a regional director include operational oversight of about 32 of our 70 offices. So all the offices in Pennsylvania, South Jersey, Delaware, and Maryland. And then in addition to that, I oversee a couple of support offices related to clinical practice. So functionally, I'm the chief clinical officer for the practice as well.
And more specifically, what does that include?
So from the chief clinical officer perspective, actually I was hired at Bayada 4.5 years ago to start an office called the Clinical Leadership Office. I still oversee that office as well as the Office of Regulatory and Quality Affairs. So things as important and perhaps mundane as compliance, but definitely important. So responsible for compliance, overall quality improvement efforts in the practice, but then program design around best practices. Heart failure, joint replacement, and then spending a lot of time talking to hospital systems, large physician practices around alternative payment models, bundled payment, ACO, and so all of that sort of wrapped up into those responsibilities.
Tell us briefly your history in healthcare.
So my history in healthcare. So I started out as a PT, still am a PT, but started out practicing as a PT in 1990, had my bachelor's degree from Northeastern University, worked in a small town hospital, inpatient and outpatient, moved to Philadelphia a year later, so I've been in Philadelphia now 22 years, doing outpatient sports medicine and home health, actually 50-50, which is an interesting combination. From there, continued doing some practice in home health when I then shifted into an academic position. Working on my master's degree in orthopedic physical therapy. Was at Hahnemann University for 5 years doing the academic piece, both as a student and as a faculty member, and doing some clinical practice. Finished my master's degree in orthopedics, got my OCS through APTA, and then went to work at the University of the Sciences as a full-time faculty member for 5 years. And there, it was a split position, 40 clinical, 60 academic, and that's part of why I took the job. And so the 40 that was clinical was working in the Mercy Health System, creating a pro bono physical therapy clinic, creating fitness centers in the West Philadelphia community, so a lot of community health stuff. And that was engaging enough that after 5 years at USP, I decided to leave academia altogether. Worked for the Mercy Health System full-time for an additional 5 years, helping to really get the pro bono clinic running, some of those things. And then the opportunity came up about 4.5 years ago to take the position at Bayada. And was very happy at Mercy, but the reason I took the position at Bayada was the opportunity to create, in essence, this role of chief clinical officer. And the regional and operational stuff that I'm doing was nothing I had anticipated. But what I'm finding is, if you're on the operations side, you're the one that can help hardwire the things that make sure the quality stuff happens, which as a clinician is the stuff that really gets me out of bed, excited to go to work in the morning.
And somewhere along there, you got a PhD.
That's right, I did. So when I went to USP, they had a PhD program in health policy. And when I was at Hahnemann, I was doing my service activity in our local district, and I was the legislative committee chair, and sort of got involved with legislative activities, became the chair for the state committee, and was very active in getting the Direct Access Bill passed in Pennsylvania. And then in 1997, the Balanced Budget Act passed, and it had impact on rehab services. So in 1999, as a faculty member, the provisions that impacted rehab went into effect January 1st of 99, and in May or June, when the PT class was finished at Hahnemann at that time, half of the students couldn't get a job. Prior to that, everybody could get jobs. I mean, my hometown hospital paid my last year of tuition for me to come work for them for 1 year, with no cut in salary. I mean, I got the full salary. I mean, it was, so I've been rather spoiled. So when I realized that the stroke of a pen could have a significant impact on rehab services and your ability to provide care, it just changed the way I looked at the world. So I was planning to go and get a PhD in biomechanics, because my master's is in biomechanics. But the legislative work and so forth, I realized that policy was probably the better way to go. If you're going to try to fix the system, you got to, and the people that run the system speak Greek, you learn Greek, and health policy to most people is Greek, but to me it's fascinating. So I finished my PhD in health policy probably about 5 years ago, 4 or 5 years ago.
And as you look at as you read the tea leaves related to healthcare today, what do you see on the near horizon and maybe the horizon 5 years, 10 years out?
So thinking about sort of broadly healthcare. So on the near horizon, it's a little bit of bedlam. because payers, and Medicare in particular, are trying to figure out how they measure value in the system. And so it's hard to measure everything. And the old saying says, not everything you measure matters, and not everything that matters can be measured. And so we're sort of struggling with, how do we pay for healthcare so that it isn't just, yes, you delivered this service, I'm going to pay you. What was the outcome? What was the value? So there's, and we're in the middle of it now, there's all these discussions with providers around bundle payment and ACO, and really what the payers are forcing us to do is to figure out how to play well in the sandbox. It's the people that I can talk to now that would never have talked to me before, not because I'm a PT, but just because I'm either not a physician or not a healthcare executive and not in a hospital or physician practice, is unbelievable. I mean, everybody's talking to everybody, but nobody has the real answer. So in the short term, it's be innovative, get creative, and be really comfortable with ambiguity, because that's basically the way it is. Longer term, I think those organizations, either as a one focused organization under the same tax ID number, or a loose confederation of organizations that are really hardwired to work well together, or that can demonstrate the best outcomes, are the ones that are really going to start to get, they're going to crowd out the rest of the field. And what you're going to start to see is mediocre providers. I just don't think are going to be able to stay in the game, whether a provider be an individual physical therapist or a hospital or a large physician practice. There's just not enough money to go around. So there's more than enough money to go around, quite honestly, if we're spending it effectively on really good healthcare delivery. But right now, we're spending a lot of money, and the results of healthcare in the U.S. were worse than every other industrialized country. We spend almost 3 or 4 times as much. So there's a problem with that equation. So longer term is the people who are disciplined can look at the data and demonstrate improvement, much like manufacturing had to do many years ago, are really going to be in the best position. And I think we'll still be able to deliver really good care. Patients will get better, and we'll just not spend nearly as much money on it, which isn't necessarily a bad thing.
So if you were talking to the CEO of an 800-bed hospital system that is embarking on a 32-bed acute rehab, how does what you just said impact her and her thinking?
So what I would say to any hospital CEO that's looking at trying to figure out how to create a continuum of care, because that's in essence what she's trying to do, or many of them are trying to do. In this case, acute services, and then into post-acute inpatient rehab, but I'll call it post-acute. Be thinking about what is it that you want to create, and do you need to own it? Meaning, do you have to create it yourself? Do you joint venture with somebody to do it? Or do you outsource it to a partner that you can trust and that you share data and so forth? Because I think those are really the 3 options. Whether it's an inpatient rehab, whether it's a skilled nursing facility, whether it's a home health organization, any health system executive has, I think, basically those 3 choices. And as much as you want to, I think any one of those can be the correct answer, as long as you feel comfortable that either on your own, with a partner, as a joint venture, or a partner who's sort of a separate entity, that you've got clear expectations and you know what the outcome measures are that you want to use and what the outcomes are, then you'll be fine. I don't think anyone's necessarily better or worse than the other. One of my observations in talking to a lot of hospital executives, and not to be critical of hospital executives, is there's this sense of, my words, nobody else's words, of I have to own it all, sort of the empire builder. And maybe that's possible, but my perspective is you can build an empire, you don't have to necessarily own the entire empire. If the goal and the outcome is to improve the care that you deliver to your community, there are lots of ways to accomplish that. In some cases, with a rehab unit, you really probably need to build that and own it. But for other more community-based services, I think that those 3 options earlier are things to think about.
What other sorts of community services are you thinking of?
So when I think about community services, I think about physician services. So do you buy the local physician primary care practices, and that's part of your health network? Do you partner with them in a joint venture? Do you trust that they're good partners and measure each other and just refer your patients to those primary care physicians who demonstrate that they're using all the HEDIS measures and they've got the right outcomes and so forth? I think about skilled nursing. I think about home health for certain. And probably even I think about other community-based services, the areas on aging, the public health services in communities. Because if you're a hospital executive, if you're anybody in a community that really cares about the health of the community, then anything that happens outside of the four walls of the hospital is our community-based services. So thinking about, let's go even broader than that. So as a hospital executive, should you be thinking about making sure in the neighborhoods where disease is most prevalent that there are really good grocery stores, right? That there are options for people to make choices to stay healthy that are outside of a pill or a shot or the things that we typically deliver in a truly sort of clinical environment, because the social determinants of health are the bigger drivers. Things like, will you support the creation of sidewalks, of walkway, of just getting people moving alone. Now, as a physical therapist, I'm a little biased, but there's a lot of recent evidence that says because our work has become so sedentary, it's actually the next scourge as far as healthcare is concerned. So it really is, what are you doing to help your community stay healthy? And it's much more broad than, did you give them a flu shot?
Wow.
That's funny, because I was just thinking, did I answer the question?
Yes.
I'd be curious when we're done for you to unpack a little of what you said about, as an industrial nation, we're like the worst and we're 3 times, and I've heard similar statistics. I'd be curious.
I think the
Just
latest
anecdotally.
statistic is 57th, right behind the Dominican Republic in terms of just general
Oh, the
health.
World Health Organization?
Yeah, that's World Health Organization.
Yeah.
And that's the Dominican Republic, what the heck? So, I mean, in trauma care, we're number 1.
Yeah.
But, boy, I'll
That's
tell
right.
ya,
Yep. If you get really, really sick, this is the place to be.
Sure.
But we're set up to make sure you do, because that's where we make our money and that's how we've designed our system.
Yeah,
So
I mean-
the downstream, we're not a primary care nation. We're just not.
Of course, we have no trans fats, but cigarettes are fine.
Right.
So, I mean, it's like the eclipse of reason regarding those things is just.
It's
and
staggering, isn't it?
It's money, it's lobbies, it's, yeah, just
Yep.
frustrates me.
Yes. Me too.
Do you
Yeah.
wanna,
So actually, just right. So when you look at this concept of the United States is founded on rugged individualism. I mean, think about the Marlboro Man. Speaking of smoking, right? Was an icon, but not an icon because he smoked, but he was an icon because he was this tough, rugged individual, and I can take on anything I want. And quite frankly, I don't want to give that up as an American. I think that's that, and we're chronically optimistic as a country, which I love. But that said, this individual streak really has us forget to think about the whole. We spend a lot of time thinking about the sum of the parts. And so when we talk about how good healthcare is, we talk about how good it is with the assumption that we're talking about everybody. What we really mean is the people that can afford it. Because we have the best healthcare system in the world by far. Well, we have it the best. There are others that are really good, so I don't want to sound too snooty, but only if you can afford it. So for a lot of people in this country, we don't have a healthcare system because they don't have access to it. And what they have access to are public health services, which are unbelievably good considering how few resources these folks have. I mean, working with the city of Philadelphia's Department of Public Health for many years in our pro bono clinic when I was at Mercy, what I learned was these are dedicated people that the care they deliver was really good. It was really good because there's a stigma about public health. Oh yeah, you're going to get the doctor who passed their board exam but was last in their class. People I worked with were smart, and they weren't getting paid very much, so they were there to do the right thing. But just sort of this idea of, if we're talking about population health, you've got to think about how do you take care of populations, and our system isn't designed to do that. So as a hospital executive, if you're thinking about, the way to think about the way to think about population health is to think about your community, and what are all the things that your community needs, in addition to your hospital and your inpatient rehab facility, that's truly going to improve health. Right? And we talked earlier about the World Health Organization. Every opportunity I get, I say their definition of health, 1954, I think it came out, mid-50s, is my favorite definition of health, right? So, and I'm probably going to paraphrase, but physical, social, and emotional well-being, not merely the absence of disease, which I love, because right now, what we're focused on in this country is the absence of disease, and we've missed this other stuff. The good news is all the other industrialized nations are shifting even more and more to that model. So ICD-10 starts to get at that more than the ICD-9 is. But remember, ICD is International Classification of Disease, right? Internationally, there's ICF, right? International Classification of Functioning. And most of the nations are moving towards ICF because in the end, what people really care about is, yeah, I want my diabetes managed, and I want to be sure my heart failure doesn't have me so short of breath that I can't function, because what I really care about is I want to get to my grandson's baseball game. I want to get up the stairs because I only have a bathroom on the second floor. I want to be able to get up and down by myself and not need help. Function. That's what people really care about. So managing heart failure symptoms only gets at one piece of that. You got to make sure that you're managing functional ability, and then also that they feel like they've got some sense of social well-being. They've got a safety net. They've got people that care about them. All those things make a big difference. But the system is not designed to help that be to optimize that broad of an outcome consistently for people. And that's where our opportunity is.
So have you seen examples of that in any communities in which you've been involved that you think could be held up as examples of excellence?
So examples in community that look sort of more broadly, I see examples in every major city that I go to. If I look at the collection of services that are available to people in cities, it's really impressive. Much of it's volunteer, much of it's sort of nonprofit, sort of wholly underfunded, but really propelled by people who mean to do well. The problem is it's not connected. And the thing that opened my eyes to this is when I left the University of the Sciences to go to Mercy. Part of the reason I did that is we'd gotten a $2.1 million grant from HRSA, Health Resources Services Administration, to create this system of care. And what we spent that money on was simply creating a hub that people could come to, and we could connect them to all the social services that were available. We didn't have to create any of the services. We just had to connect them. So there's a ton of stuff out there, but there's no connection. And even hospitals, that's part of the problem with readmission. Hospitals are losing all sorts of, Medicare and payers are losing all sorts of money on people going to the hospital, coming home, and then going back in a very short period of time. Part of the reason is the hospitals, who all mean well, when they leave the hospital, it's like, I did my job, I'm done. Rather than thinking about, I'm only done if that patient doesn't come back in to see me for 6 months or whatever. It's really sort of, I get paid for what I do and not anything outside of that. And so it's unfortunate. And I'm not picking on hospitals. We're all myopic as far as the way we deliver services. The physical therapists, I do the things I need to do. I gave them their exercises. They're adults. They know better. When they go out, if they don't get any better, not my fault. And maybe it's not your fault, but are there ways that you could have connected them to the next level of service to sort of hand off until people get to the point where they've got really the true physical, social, and emotional well-being? So I see it out there. I just don't see it connected. So I see all this opportunity, but we're missing it because we keep doing this. That's where I get frustrated.
Okay.
Do you remember the question?
No, not exactly. I think it was about, how do you actually, do you instill this in something?
Oh, right.
Person? Does it come from within? What would put the feet on the ground with this idea?
Right. So the idea being, how do you engage patients and just people? I'll call them pre-patients. How do you engage people, right? So they don't become patients. And so part of the question is, who does that? Do they do it internally? Do they need a coach? Does somebody help them? And I think for me at this point, part of what I see is us creating ways to help them navigate a broken system rather than addressing a way to fix the system so it's intuitive and it engages people, it gives them every reason to make the right decision, and it gives them the right sort of recognition and reward when they do that. I'd used the example before of Apple, so an iPhone, somebody goes in, it's intuitive. They can figure, for the most part, they can figure a good portion of it out on their own. The look of it, the feel of it, that organization, and I own no Apple stocks, and there are other examples, but our system needs to have taken as much time to think about the consumer experience as Apple and others have done, and we haven't done that. The experience, hospitals are designed around the providers. They're designed to make it convenient for the physician, as well as the physical therapist and the occupation. I'm going in to get my job done. I need to have everything in the right place with very little consideration for what is it that makes the experience valuable to the patient, right? Because if you think about social determinants of health, you think about social, emotional, and physical well-being, how you feel when you walk into a hospital can have as much impact on how quickly you heal as what they do to you when you're there. And you're starting to see some places begin to look at that. So hospitals are beginning to look more and more like luxury hotels. I'm not sure the cost makes a lot of sense, but the concept is right. Is you should to some degree, I don't want to say you should be glad you're there, but when you're there, you should feel like it's a comfortable, sort of warm environment, because all of the stuff that happens up here affects everything that happens sort of through the rest of the body. So I think we start by fixing the system and making it easier for patients to sort of navigate and do the right thing. And then for those patients that are challenged with making good decisions, then provide them with the additional support, rather than trying to hold everybody by the hand. We're just not enough of us to do that, quite frankly.
Good.
I'm totally off script here.
Excellent.
You succeeded.
He always does. There's a lot to talk about aging in place as
Mhm.
the baby boomers grow and enter retirement and get older. What are some of the hallmark things that need to be looked at, given the population change?
So, for the concept of aging in place is one that people, I think, gravitate to really quickly. So who wouldn't want to age in place? So, on face value, it has tremendous validity. But to age in place, again, you've got to create an environment that is safe and promotes health and well-being for people. So, again, I think if our system continues to be structured around high-tech four-wall institutions, people are going to be less and less comfortable that when I'm at home, I'm getting the care that I need. Somehow there's something magic that happens when I go into the hospital. And if I don't go in there, the care is going to be different. It's not going to, and in fact, it may be different because you can get an MRI in there, and getting one at home is a little difficult. The system has to be restructured to make it easy for the care to come to the person. And then, as I mentioned before, the community has to be designed so that people who want to age in place can do the things that help them age gracefully in place. So they've got to have places to walk. They've got to have access to good food. They've got to have access to services that can come right to their home. And it's interesting, because of the cost of healthcare, the push to moving people out of the hospitals and out of skilled nursing more quickly is accelerating, meaning more and more people are getting service in their home, which is the way it had started. Right? In the 1900s, in the early 1900s and the late 1800s, all care was delivered at home. And then we invented this hospital, which was this great idea, especially once we had specialized medicine. And so you come in the hospital, you truly could get something you couldn't get at home. But I think we sort of tipped it to the extreme, and forgot that you can do a good portion of the care that you need at home or in in the community, family physician practice, exercise, fitness facility. So if you want to age in place, you've got to create a place that allows for good aging. And just having four walls around you and a roof over your head is not enough.
So insurance for rehab will pay for a portion,
Mm-hmm.
and people probably do not have the financial ability to pay for it on their own. So talk to prospective donors.
Mm-hmm.
What will their dollars get them?
So if we think about paying for, I'll broaden it, paying for ways to improve people's function, right? So, and by virtue of that, the expectation is you're improving quality of life. Hopefully quantity, but most certainly we want quality of life. If I can function better, quality of life. So I think that insurance is only going to get people so far, but I believe that particularly as baby boomers age, they're not going to be satisfied with a mediocre quality of life, and particularly mediocre function. They want to be playing tennis till they're 90. And so rehab services and things that will improve function are going to become more and more necessary. And for the people that can't pay, I think part of what a donor's dollar will provide is the ability for that person to age in place and stay home safely. There's lots and lots and lots of evidence around the benefit of just exercise and activity. So by virtue of helping them get the rehab services that they need to get them to a level where they can maintain on their own, or have maybe a lower level, a person with less educational experience and therefore less expensive, a community health worker, for example, check up on them with some regularity to just sort of do the coaching and keep up the good work. You can stretch $1 a long way. And then maybe the PT comes in every now and then to just sort of double check the program and so forth. By virtue of improving their activity level, you decrease their diabetes, their hemoglobin A1C specifically. Exercise directly impacts that. Their weight, their joints because of muscle strength. So all the things that let people get out to see their grandkids play in the baseball game happen because you're managing the disease, but really you're managing their sort of functional level. And what we're starting to see, as I mentioned before, is that's all they've really wanted. We've sort of diverted them by saying, we'll get you there because we're going to take care of your heart failure. Not that we don't want to take care of the heart failure, but in the end, they want to go to the baseball game. And so for people that can't afford rehab services, it's going to give them the opportunity to basically get out into the community. And so if you want a vibrant community, people have to be out in the community. And so the donations, whether people paid out of their own pocket or whether a donor helps with that, I think what you're giving people is the opportunity to interact in their community, be active members of their community, and then that has a whole spiraling positive effect that I think builds on itself over time.
Good, let me cut you, I gotta change the battery.
I think he's got about 2 minutes.
Stand by. Okay, we're rolling.
All right. So I'll just answer that question. So one of the things that is, I think, a real benefit if you're going to add a service to your health system or connect to services in the community and create this continuum, is that if a person comes into the hospital and has a seamless transition to your inpatient facility, rehab facility for this example, and then hopefully has a seamless transition to home and then back to their primary care physician and to whatever other services they need. You know, basically what you're creating by creating a seamless continuum of care is you're creating a community that cares. I mean, it sounds simple, and it actually almost sounds as if it's not worth it because it doesn't sound scientific enough, but that's what people are looking for. They're looking for a health system that they feel when they go in, they don't feel like they're a number. They feel like people care about them. And when you do it a place that's close to them, literally, physically close to them, there's a good chance that the person in that inpatient rehab facility lives in their neighborhood. And even if they don't, that person knows their neighborhood, and there's that familial, not familial, but it feels familiar connection that people have. And what we undervalue and I think underappreciate in healthcare is the human connection that people make. So that conversation that you have with the aide in the inpatient rehab facility or the physical therapist or the physician, even in the hospital, that has nothing to do with what you're in there for, but the connection to the local baseball team that your son's on and his son coaches, that stuff really makes a difference in overall health. But I don't think we realize that. But if you're thoughtful and tactical and strategic about making sure that you create those opportunities, then to me, that's value. It's hard to measure, but you know it when you see it. And so bringing in an inpatient rehab facility to a hospital system to keep people from having to drive an hour to a completely different community where they don't have the same kind of connections with people diminishes their opportunity for improvement, I think, compared to what you can do closer to home. I think that's the real win.
That's great.
Wow,
That's
excellent,
Good
yeah.
question. You've clearly done this before.
Isn't it good that they hired you?
Yes, well, Karen's put so much work into
Oh,
this.
that's nice.
They're the brains.
Yeah.
The clinical consultant. Yeah, we have,
Yeah,
it's enough. Any other last, I mean, that was good. Anything else?
no, that's a key thing from what I understand. I mean, I feel like somewhat of a neophyte coming into this because there's so many layers of complexity in what they're trying to
Right.
do. But that seems to be, when we talked with Elaine, that she seems to, well, it was interesting, because I kind of came to the meeting with a little bit of skepticism. I try not to be cynical.
Because then the heart of it's sort of not there. No pun intended with cardiology, but you know what I mean.
Yeah, no, that's a good point. That's a really good point. Okay, we really do have to wrap
Yeah.
up. You do need to go down and set up.
Okay.
What are you going to